right, thank you, Dr. Dupuy, and thank you to the Society for inviting me to present. I've got 15 minutes to give you a very quick primer on PET perfusion tracers. Here are my disclosures. PET is quite a flexible modality. I'm not going to go through all of these or really even any of these, but just to put in your mind that there are a large number of tracers available and that have been developed over a long number of years. You'll notice two things on this slide, really. One of them, if I have a cursor, that many of our tracers are labeled with F18. F18 doesn't occur naturally in the body, but it can be, many compounds can be labeled through a deoxy substitution of fluorine for a hydroxyl group. And in particular, I'm going to focus, you'll see FDG, our colleague here, and some of the perfusion agents. So this is an interesting slide. There are, radioactive isotopes. Hopefully this isn't too sacrilegious, but one thing that distinguishes PET from some of the SPECT tracers is that these compounds are not made by nuclear reactors. These are, in some instances, getting away from reactor-produced isotopes. Most of the common tracers are produced with cyclotrons and a smaller number with generators. So I am a physicist, so I have to give a little bit of physics, but I promise I'm going to transition very quickly into biology and imaging. A conventional PET cyclotron will make really four principal isotopes: fluorine-18, which, as I mentioned, can be used in chemistry to substitute for hydroxyl groups. N13, which has a shorter half-life of 10 minutes, is used almost exclusively for N13 ammonia labeling, which is a perfusion agent. Carbon-11, oxygen-15, which has been used in research for many years to label water, which is really our gold standard for blood flow quantification. And in fact, strontium-82 is also made not by a PET cyclotron, by a higher energy cyclotron to produce rubidium in our rubidium generators. The cyclotron really is either a proton or a negative ion accelerator. It's a fairly large infrastructure. There are smaller variants of cyclotrons available. This is not a generator. It is still a cyclotron, although a cyclotron with a much smaller footprint that's tailored to producing N13. This is a relatively new player on the market. So if I look at this table in this review by Frank Bengel in 2009, there were really only three tracers approved for cardiac imaging. The first was rubidium, actually approved in the late 80s, N13 ammonia, which we heard a little bit about, and our old friend FDG. In fact, sodium fluoride was also approved at that time, but had not yet been kind of promoted or realized for cardiac imaging. I will come back to that a little bit later. I found on one of the vendor sites, current list has expanded somewhat. We've now got more than double that number of tracers. Still N13 ammonia, rubidium, and FDG are on the list. Sodium fluoride has been kind of re-added. An interesting selection of tracers to look at amyloid plaque developed for neurological imaging, but may also actually have some cardiac applications. So PET perfusion imaging is obviously the mainstay of cardiac nuclear medicine, and we have a number of PET tracers to choose from. Many of these have been used in research literature. At the moment, two of those are approved and available for routine clinical use. Rubidium, which can be obtained from a generator, which is really nothing more than a little ion exchange column, or ammonia, which requires a cyclotron either on site or nearby, given quite the short half-life of N13 ammonia. So I'll go through a few slides for describing, what is rubidium and why is it useful for perfusion imaging. It's a column 1 metal, and you'll notice it's right below potassium on the periodic table. So it's in fact a potassium analog, and it has atomic radius similar to potassium and behaves in much the same way as thallium, which is a SPECT perfusion tracer that many of us are familiar with, and its uptake is through the sodium-potassium ATPase, which is always pumping sodium out of cells with an intact cell membrane, and potassium in, and rubidium follows naturally through that potassium channel. Rubidium, it is a result. It's produced by strontium decay, and in a strontium generator, we have a parent compound with a half-life of 25 days. Rubidium itself is ultra short, so it decays with a 75-second half-life. And basically, this property of radionuclide generators is, as I said, nothing more than an ion exchange column which will bind elements in column 2. When strontium decays to produce rubidium, it now has a different electron valence. It's no longer bound to the column and can simply be eluted off by flushing with saline with radioactive rubidium chloride eluate. Right after eluting the generator, you can see here at time 0, the blue curve shows how quickly rubidium will regenerate on the column. So something after 4 daughter half-lives, remember the half-life is a minute and a quarter, so at 5 minutes, 95% of the rubidium is available again from the generator to re-elute. So you can elute or perform a rubidium perfusion study basically at 5-minute intervals. That means that there's really virtually no practical limit to the number of studies you can do with the generator once you have it on site. So what would a protocol look like for rubidium stress or rest and stress perfusion imaging? As you saw on some of the previous slides from Dr. Bateman's group, booking on a 30-minute schedule is really quite feasible because the total imaging time is somewhere around 15 to 20 minutes. A short CT scan, if you have PET-CT, 5 to 6 minute rest perfusion scan. Pharmacologic stress can be as short as 1 minute with regadenoson or an 8-minute protocol with persantine, followed by stress imaging. A stress first protocol would shorten this for some patients. Obviously, if the stress scan was first normal, you may not then need to proceed to the rest scan. So again, the protocol, something like this: 6 to 8 minutes rest, short stress, stress perfusion scan. In our center, we perform a separate rest attenuation scan, which is a very low-dose scan, and an optional CT for those patients that don't already have a diagnosis of coronary disease. Here's what a typical rubidium image quality will look like. This isn't necessarily a small patient. This is simply a patient that I grabbed from the last couple of weeks. You see stress on top, rest on the bottom, in polar maps showing a stress-induced perfusion defect that improves at rest with ischemic reversibility being very apparent. Some of that apparent benefit compared to the SPECT technetium tracers comes from improved extraction properties of rubidium at stress, where you may be able to unmask or visualize perfusion defects with a little bit more severity using a PET perfusion tracer. Moving on to ammonia. Ammonia, the uptake mechanism is a little bit different from rubidium. Purpose of this is not to go through the math, don't worry, but simply to show you the biologic pathway for ammonia uptake. Ammonia crosses the capillary and the cell membranes as ammonium ion, and then it is trapped and converted into N13 glutamine, so it's part of the glutamine synthesis pathway. That means that it is a metabolically dependent process, and this may be more sensitive to regions of ischemia, for example. One of the advantages of ammonia, it has very high first-pass extraction fraction, so if you're doing dynamic imaging with PET, you can very easily get quantitatively very robust estimates of myocardial blood flow with ammonia. And the mathematics are actually fairly similar to rubidium, although you need a larger extraction correction to measure blood flow with rubidium compared to ammonia. The imaging time with N13 ammonia would be a little bit longer than with rubidium. With rubidium, there's really no point in scanning much longer than 5 minutes because your tracer has pretty much all decayed after that point. With ammonia, with a 10-minute half-life, you can afford potentially to scan a little bit longer if you'd like to acquire more count statistics and acquire an image with perhaps a little bit higher spatial resolution. One of the big advantages of ammonia, of course, is that you can also do treadmill exercise. So you can exercise, inject the tracer at peak stress, and then put the patient in the camera, at least to do relative perfusion imaging. If you are going to use exercise, will not be able to do dynamic imaging for blood flow quantification, obviously. So you need to choose either exercise MPI or pharmacologic stress with flow quantification. Again, the protocol generally looks very similar, just that each of these imaging times might be a little bit longer. Some labs will also wait a certain interval after the rest ammonia scan to let some of the activity decay, or in some labs, similar to what we do with SPECT imaging, inject a higher activity at stress to try and sensitize the stress images to regions of ischemia, but then you may have a little bit of a rest background still to contend with. Here's an ammonia perfusion scan, actually in the same patient that I showed you with rubidium. These are actually only the rest scans, and I'd ask the audience to tell me one of these is rubidium and one of them is ammonia. So take a look. Who thinks ammonia is on the top? Who thinks ammonia is on the bottom? All right, more ammonia. All right, but there were a few who thought it might be ammonia on the top. In fact, it is rubidium on the top. I'd argue the spatial resolution is quite similar. You may get a little bit sharper spatial resolution. The biggest difference between rubidium and ammonia is actually that you can delay the start of imaging a little bit and get a little bit better myocardium to blood contrast. But in general, I would say the image quality is extremely comparable. The background organ or adjacent organ uptake is a little bit different for ammonia compared to rubidium. Rubidium, we can have focal uptake in the stomach walls, which you can also see with ammonia. Ammonia can have quite intense uptake in the liver, which in some cases can mask inferior wall defects. Ammonia also has a normal variant reduction in the lateral wall in some normal subjects, which can make interpretation of lateral wall disease or ischemia a little bit more complicated. Again, blood flow imaging helps to clarify that. Very briefly, I'll mention another tracer that's under development, not approved yet. Some of the initial results for flurpiridaz in phase 3 trials were announced at the end of last year. And so we're, as a community, anxiously awaiting for approval of this agent. By all accounts, it has very similar imaging properties to N13 ammonia. Again, incremental dosing regimen that's being recommended and amenable now to treadmill exercise or farm stress. A short protocol, again, might be 3 millicuries at rest followed by 10 millicuries at stress. The advantage here, of course, is that there's a network of cyclotrons across the US and North America that could, in theory, manufacture and distribute this tracer. So it would be amenable for sites maybe that wanted to get some initial experience with rubidium PET without necessarily the investment of a rubidium generator or a cyclotron. These are the kinds of images that you can get with flurpiridaz. This was one of the phase 3 subjects acquired as part of the trial at our center. There hasn't been any post-filtering applied here. You can see very high resolution, spatial resolution, as well as myocardium to blood contrast resolution, and nice definition, for example, of mild ischemia here in the inferior wall. One important consideration in choosing tracers, which is becoming more and more important in today's environment, is radiation dose. Rubidium and ammonia at the doses that are used both for 2D and 3D imaging are on the order of, I'd say, 1 millisievert per scan if you're using a 3D camera, maybe 1.5 to 2 millisieverts if you're using an older generation 2D machine. The F-18 agents, because the half-life is longer, you would have 1 millisievert dose for 1.5 millicuries. So if you're talking 3 plus 10, you're going to be probably in the range of 5 to 7 millisieverts, very similar to the dose that you would have for an FDG PET scan. We're all familiar with FDG PET for viability imaging. Again, this is the same patient that I showed with ammonia and rubidium. In this case, we have FDG on the top, rubidium on the bottom. With viability imaging, it's of course important also to acquire a rest perfusion scan so that you can compare the distribution of glucose metabolism with perfusion, in this case showing a matched area, predominantly scar, perhaps with a little bit of viability or mismatch at the margins. Again, there are quantification programs available to help quantify this in terms of percent left ventricle with either scar or hibernating myocardium can help to direct therapy and improve prognosis. Here's another example of mismatch perfusion, which fills in on FDG, in this case a larger area of mismatch indicating hibernating myocardium that could be expected to recover function with revascularization. And very briefly, just to touch on a couple of the other emerging indications beyond the standard perfusion and viability. There'll be many talks at this meeting dealing with cardiac sarcoid. Again, whole body imaging, perfusion, and in many cases ammonia recommended as part of the new guidelines. Other novel tracers, FLT, may emerge as another alternative to FDG, advantage being no myocardial background signal to complicate interpretation. And finally, I mentioned at the start, there is a selection of beta amyloid tracers developed for brain Alzheimer's imaging, but there are actually some amyloid, cardiac amyloid applications potentially to help distinguish between different subtypes of amyloid that can have impact on patient therapies. Sodium fluoride, also developed originally as a oncology scan for bone mets, may have some research applications potentially emerging. We would wonder for clinical applications to look at vulnerable plaque or calcified plaque in coronary arteries. This may be something that we see coming down the road. And so to close, in selecting your perfusion or your PET tracers, consider your standard myocardial perfusion imaging patients, viability patients, and emerging indications such as device inflammation, sarcoid and amyloid imaging, as well as vulnerable plaque. Thank you for your attention.